Okay, so today we are going to talk about jaundice workup. Jaundice is the yellowish discoloration of the skin and the scleral icterus. Jaundice occurs whenever there is excess bilirubin in blood. We have a case here. A 50-year-old man comes to office with fatigue and malaise for the last 2 weeks. Physical exam shows yellowish discoloration of skin and the eyes. Blood pressure is 110/70, heart rate is 87 per minute, temperature is 38.9. Liver is palpable below the costal margin and is tender. How will you proceed forward? So if you look at this case, this patient presented with the chief complaint of fatigue and malaise for the last 2 weeks. Other than that, an important finding on physical exam is jaundice, yellowish discoloration of skin and eyes. Important finding on abdominal examination is tender liver. How will you proceed forward? Today we are going to talk about that. Whenever a patient comes to you with jaundice, after going for history and physical exam, you have to go for 3 tests. What are those 3 tests that you have to go for? You have to go for liver function tests, liver ultrasound, and urine for bilirubin. First, we will talk about how bilirubin is formed and how it is excreted from body. Bilirubin is formed whenever there is hemolysis and RBC breakdown. RBCs contain heme and that heme is converted to unconjugated bilirubin. Unconjugated bilirubin is water insoluble. It binds to albumin and is transported to liver, where unconjugated bilirubin is converted to conjugated bilirubin by a rate limiting enzyme UDP glucuronide transferase. Conjugated bilirubin is water soluble. Water-soluble conjugated bilirubin is thus excreted in gut. Coming towards UDP glucuronide transferase is a rate-limiting enzyme. Rate-limiting enzymes means that whenever there is excess breakdown of RBCs and excess unconjugated bilirubin is formed, that excess unconjugated bilirubin cannot be conjugated by this enzyme because this enzyme gets overwhelmed and overworked, and therefore unconjugated bilirubin rises in blood. Whenever unconjugated bilirubin rises in blood, this is a prehepatic cause of jaundice. Because everything is okay with liver, everything is okay with the excreting system of conjugated bilirubin, but unconjugated bilirubin is formed in excess that liver cannot conjugate. Sometimes it happens that bilirubin is conjugated, but that conjugated bilirubin cannot enter gut because there is something wrong with the excreting system. There is something wrong with the biliary tree. Either there is a stone present in the biliary tree, or there is a tumor present in the biliary ducts, or there is primary biliary cirrhosis, primary sclerosing cholangitis, where the biliary tree is destroyed. So conjugated bilirubin cannot enter gut and it is backed up in liver. When conjugated bilirubin is backed up in liver, it leaks back into blood and there is rise in conjugated bilirubin. Rise in conjugated bilirubin shows that there is post-hepatic cause. There is something wrong with the excreting system. So conjugated bilirubin backs up in blood, and conjugated bilirubin is water soluble and it can enter urine. It can be excreted in urine. So whenever there is rise in conjugated bilirubin in blood, it appears in urine and urine becomes dark color urine. Other than that, conjugated bilirubin in gut, in stools, normally is converted to stercobilin, and that stercobilin gives the normal color of stools. So whenever there is no conjugated bilirubin entering gut, there is no stercobilin and the normal color of stool is not there. The stool color is pale. Whenever stools are pale and there is dark color urine, it means that bilirubin is not excreted in gut, it is being excreted in urine. So this shows conjugated hyperbilirubinemia. So in summary, whenever there is rise in unconjugated bilirubin, the causes are prehepatic. Unconjugated bilirubin cannot enter urine because it is water insoluble, it is fat soluble. And whenever there is rise in conjugated bilirubin, it means something is wrong with the excreting system, and conjugated bilirubin is water soluble. It can appear in urine resulting in dark color urine. Plus, conjugated bilirubin also give normal color to stools, and whenever conjugated bilirubin is not entering gut, the stools are pale. So conjugated hyperbilirubinemia. Coming towards hepatic causes show a mixed picture. In hepatic causes, there is both rise of conjugated bilirubin and unconjugated bilirubin. Either there is defect with this enzyme glucuronide transferase, or there is a defect in the transport of conjugated bilirubin from the hepatic cells to the bile canaliculi, and there is elevation of bilirubin. So hepatic causes show a mixed picture. So you did liver function tests, liver ultrasound, and urine for bilirubin. If liver function tests are normal, it means that this is not a hepatic cause, because if LFTs are normal, liver is normal. Hepatic causes excluded. If ultrasound is normal, ultrasound tells us about post-hepatic causes. Ultrasound tells us about the biliary tree. If ultrasound is normal, post-hepatic causes are excluded. If it is not a hepatic cause, if it is not a post-hepatic cause, then it is most probably a pre-hepatic cause. And urine is negative for bilirubin. So this is a pre-hepatic jaundice. If it is a pre-hepatic jaundice, the next thing you have to see is whether this is due to elevation of conjugated bilirubin or unconjugated bilirubin. Whether this pre-hepatic jaundice is due to unconjugated hyperbilirubinemia or there is conjugated hyperbilirubinemia. If it is unconjugated hyperbilirubinemia, the next thing you have to go for is you have to see blood smear. Check blood smear and retic count because you suspect hemolysis, because as we talked that whenever there is hemolysis, excess unconjugated bilirubin is formed, and that unconjugated bilirubin cannot be conjugated. The enzyme is overwhelmed and it results in jaundice. So if blood smear and retic count give you positive result, it means that this was due to hemolysis. If blood smear and retic count are negative, if they are normal, it means it was not hemolysis causing elevated unconjugated bilirubin. If blood smear and retic count is normal, then it is most probably Gilbert syndrome. What is Gilbert syndrome? Gilbert syndrome is a genetic disorder in which there is decreased activity of UDP glucuronide transferase, the conjugating enzyme. If there is decreased activity of conjugating enzyme, there will be isolated elevation of unconjugated bilirubin. Mostly these patients are asymptomatic, they do not show any symptoms, and their condition is exacerbated whenever they are fasting or they have fever, alcohol, or infection. They are asymptomatic mostly, but they can show mild jaundice sometimes. Treatment, usually no treatment is required for Gilbert's. So if you did blood smear and blood smear showed that hemolysis is there, you go for hemolysis workup. If blood smear and retic count were normal, it means that this was not hemolysis causing unconjugated hyperbilirubinemia, it was Gilbert's causing unconjugated hyperbilirubinemia. Coming toward elevated conjugated bilirubin. Elevated conjugated bilirubin will appear in urine, and urine will be positive for bilirubin. But you will be thinking that why are we classifying conjugated bilirubin elevation under the heading of prehepatic jaundice? Actually, when you did LFTs and LFTs were normal, it means hepatic cause was excluded. You did ultrasound, ultrasound was normal, post-hepatic causes were excluded. If it is not a hepatic cause, if it is not a post-hepatic cause, then it is most probably pre-hepatic. But when you found that what was the type of bilirubin, it was conjugated bilirubin. Basically, these are hepatic causes causing elevation of conjugated bilirubin. These are Dubin-Johnson and Rotor syndrome. These are hepatic causes, but they appeared as if they were pre-hepatic causes, and you found them in the workup of pre-hepatic jaundice. You found these hepatic causes in the workup of pre-hepatic jaundice. These are not pre-hepatic causes, these are hepatic causes, but they look like as if they are pre-hepatic. So elevated conjugated bilirubin cause is Dubin-Johnson or Rotor syndrome. What is Dubin-Johnson syndrome? Dubin-Johnson syndrome is basically an autosomal recessive disorder. It is a benign condition in which there is defect in the bile canaliculi transport protein. liver cells are conjugating bilirubin, but that bilirubin from cells cannot be transported out into bile canaliculi. So there is isolated elevation of conjugated bilirubin, and there is defect in the bile transport canalicular protein. That conjugated bilirubin accumulates in the hepatic cells and it cannot be transferred into the bile canaliculi. Liver is grossly black, and the cause of liver being grossly black is due to the epinephrine metabolites that accumulate in liver. It is not the conjugated bilirubin causing the liver to be black. It is basically epinephrine metabolites that are also accumulating in liver in Dubin-Johnson. Mild chronic recurrent jaundice treatment, usually no treatment is required. Rotor syndrome is same as Dubin-Johnson, but the only difference is that liver is not black. Liver, there is no discoloration of liver because epinephrine metabolites do not accumulate in Rotor syndrome. Other than that, Rotor syndrome is just the same as Dubin-Johnson. But in Dubin-Johnson, on MRI, liver will be black, and in Rotor syndrome, liver will not be black on MRI. Coming towards second case in which LFTs are abnormal. If LFTs are abnormal, it means something is wrong with the liver. ALT and AST rise is out of proportion to ALP. It means that all of them are elevated, but ALT and AST are elevated much higher. They are much more elevated as compared to ALP rise. Raised conjugated bilirubin. Normal ultrasound. If ultrasound is normal, it means that the post-hepatic duct system is normal. Post-hepatic causes are excluded if ultrasound is normal. Urine is positive for bilirubin since it is conjugated bilirubin. Conjugated bilirubin appears in urine. So this is a picture of hepatic jaundice because ALT and AST are high and ultrasound is normal. Excluding the post-hepatic causes, this is hepatocellular jaundice. There are many causes of hepatocellular jaundice, and you do not need to go for all the tests that I am going to show you, but these are the tests that you can go for on the basis of your clinical assessment and history of patient. You can go for clotting profile, hepatitis serology, hepatitis A, B, C, autoimmune hepatitis, anti-mitochondrial antibodies, anti-nuclear antibodies, anti-smooth muscle antibodies. You can also go for copper studies if patient's age is less than 40. If patient is young as he is having hepatitis, you can go for a simple slit lamp exam to exclude Wilson's disease. You can go for iron studies, hemochromatosis. You can go for alpha-1 antitrypsin deficiency. If the patient is also having symptoms in lungs like emphysema and is also having hepatitis, go for alpha-1 antitrypsin deficiency. You can also go for toxicology screen if there is a history of ingestion of acetaminophen. Coming towards third case in which LFTs are abnormal. ALP rise is out of proportion to AST and ALT. ALP, AST, ALT, all of them are elevated, but ALP rise is much more as compared to AST and ALT. Whenever ALP is elevated, it shows that there is destruction of the biliary tree. Whenever there is destruction of the biliary tree, this shows post-hepatic causes. AST and ALT when elevated show that there is destruction of the liver cells, hepatocytes. So a rise in AST and ALT will show hepatic causes. Whenever AST and ALT are high, we said this is hepatocellular jaundice. Whenever ALP is high as compared to AST and ALT, it means this is post-hepatic causes. Biliary ducts are being destroyed. Raised conjugated bilirubin. Abnormal ultrasound with evidence of biliary disease. Either the ducts are dilated, either you found a tumor or you found a stone that was obstructing the flow of conjugated bilirubin from liver to gut. If conjugated bilirubin is high, it will appear in urine and urine will be positive for bilirubin. This is post-hepatic jaundice, obstructive jaundice. Obstructive jaundice or post-hepatic jaundice. If it is obstructive jaundice or post-hepatic jaundice, depending upon the patient, depending upon the cause of obstruction, you can go for cholangiography, ERCP or MRCP. Coming towards our last case in which all labs are normal. LFTs are normal, liver ultrasound is normal, urine is negative for bilirubin, and you found nothing on the tests. Then look for pseudo jaundice. What is pseudo jaundice? Pseudo jaundice occurs due to intake of high vegetable diet that results in hypercarotenemia, and carotenemia causes yellow discoloration of skin, resulting in pseudo jaundice. Other than that, other causes of yellowish discoloration can be due to Addison's disease or anorexia nervosa. Now I'll briefly talk about physiological jaundice of newborn, which is a jaundice that appears after 24 hours of birth. It is due to the decreased activity of conjugating enzyme in liver. Neonate's liver is immature and it cannot conjugate bilirubin as efficiently as a mature liver can do. So it is due to decreased activity of conjugating enzyme in liver, and unconjugated bilirubin is elevated in blood, resulting in jaundice. It has maximum intensity at 4th to 5th day of in a term baby, and there is unconjugated hyperbilirubinemia because conjugating activity is low. Serum levels of bilirubin are less than 15 milligram per deciliter. Then there is risk of kernicterus. Unconjugated bilirubin is fat soluble. It can cross the lipid membranes and it can enter brain and deposit in basal ganglia. So there is risk of kernicterus in physiological jaundice of newborn. Treatment, it is self-resolving, and what you can do is you can go for a phototherapy because UV light converts unconjugated bilirubin into soluble form that can be excreted out of the body. In summary, whenever a patient presents to you with jaundice, after doing history and physical exam, go for LFTs, liver ultrasound, and urine for bilirubin. If LFTs are normal, hepatic causes excluded. If ultrasound is normal, post-hepatic causes are excluded. Most probably it is a prehepatic jaundice. In prehepatic jaundice, look for elevated unconjugated bilirubin. If elevated unconjugated bilirubin is there, check for hemolysis and go for hemolysis workup. If there is no hemolysis, then it is most probably Gilbert's in which there is decreased activity of conjugating enzyme. If conjugated bilirubin is elevated, look for Dubin-Johnson, Rotor syndrome, which are hepatic causes that mimic a picture of prehepatic jaundice because LFTs are normal and ultrasound is normal, but there is conjugated bilirubin that is elevated and is hepatic cause. If LFTs are abnormal and AST and ALT are elevated, which shows hepatocellular damage, and ultrasound is normal, it means it is hepatocellular cause, hepatic jaundice, you can go for these studies, depending upon the history and risk factors present in a patient. If LFTs are abnormal and ALP is high, ALP shows destruction of the biliary tree, and biliary tree destruction causes post-hepatic jaundice or obstructive jaundice. Ultrasound will show evidence of biliary disease, either dilated ducts or tumor or any mass in the biliary tree. You can go for cholangiography, ERCP, MRCP depending upon the cause. If all the labs are normal, look for pseudo jaundice due to hypercarotenemia due to high vegetable diet, Addison disease, and anorexia nervosa. Thank you very much.